I'm Michael Moore, and I'm the chair of the International Immunisation Policy Task Force on immunisation. And welcome to this in a series of our webinars. And this one we've deliberately chosen polio because we wanted to tell the success stories and look at those. I'll now go to sharing my own screen, and we'll make sure that that we are ready to go. And let me start by acknowledging that personally I'm on the land of the Ngunnawal people, and I just pay respects to the Indigenous people who owned the land that I was on, and also to Indigenous people around the world, and particularly anybody who is on this webinar today. We do appreciate the support that we've had from the University of Geneva and also from Pfizer. Where's my next slide? Well, that's interesting. So let me just say a little bit about polio. You saw those 5 facts on the screen, but the average cost to fully protect a child against polio just $3. And we've already had 430 million children in total vaccinated in 39 countries just in 2017 alone. And we noticed that in terms of the cost to conduct polio surveillance worldwide is about $100 million a year. And we'll come back to that because that's an important issue. But it's also important to note that the oversight of polio is done through the Global Eradication Initiative on polio, GPEI, but it is supported by Rotary International, by the World Health Organization, by the Center for Disease Control in the US, by Gavi, by the Bill and Melinda Gates Foundation, and by UNICEF. And it is this combination of working together that has been part of building the success in polio so far. Let's have a look at those who survived polio in the early days. And this was the image that we had in the time when I can remember seeing people at school who also fitted in this category, who had these sorts of straps on their legs. So it's not so long ago that polio was having a devastating effect on the world. So what happened around ending polio? Well, look at this. It is about vaccination, and it's a vaccination around the world, and it's also people contributing in different ways to raise funds to support the efforts of those who are on the front line. And I wonder, Maria, if I can have now the 3rd slide so I can introduce our panelists. So we have to remember that at a time when there is resistance to vaccines, it's worth looking at some success stories in vaccine-controlled disease. Tonight we're going to consider, tonight for me, morning for some of you, afternoon for others. We're going to learn about the efforts to eradicate polio. Polio cases have fallen 99.9% since 1988. In 2020, Africa was certified polio-free by the World Health Organization. However, polio will remain a key public health concern until such time as there are no wild polio cases. Last year, there were over 100 cases. Until mid-September 2021, there were just 2 wild polio cases recorded, one in Pakistan and one in Afghanistan. In June 2021, the Global Polio Eradication Initiative launched the Polio Eradication Strategy for 2022 to 2026, delivering on a promise to overcome the remaining barriers and end polio despite the delay caused by COVID-19. So our panelists tonight, I'll start with Ravi, K.R. Ravindran, who was an international president of Rotary International in 2015 and 16, and chair of its Rotary Foundation in 2020-2021. He is currently chair of the Rotary Foundation COVID-19 Task Force. He's been a member of Rotary International's Polio Committee. He headed a committee in Sri Lanka consisting of UNICEF, the government, and Rotary, focused on polio eradication. And we'll come back to that later. Sri Lanka became the first country in South Asia to become polio-free. The other panelist is Michel Zaffran, who's an engineer with subsequent training in tropical epidemiology. He joined the World Health Organization in 1987. From 1998 to 2004, he represented the World Health Organization on an international working group that conceived and launched the Global Alliance for Vaccines and Immunization, Gavi. In 2006, he joined Gavi Alliance as Deputy Executive Secretary. In 2008, he returned to the World Health Organization and later headed the World Health Organization expanded program on immunization and was working with the Global Polio Eradication Initiative before he moved to Director of Polio Eradication at the World Health Organization and the committee chair of the Strategy Committee on the Global Polio Eradication Initiative. He's now retired from the World Health Organization and is also a member of Rotary International, as indeed am I. Michel, I would like to go to you first as we just clear the screen. Michel, the number of polio cases has dropped really seriously significantly in comparison to last year. First of all, is it true? How confident can we be that this actually reflects the reality? So how can you explain this rapid decline in cases?
Thank you very much, Michael, for the invitation, and thank you for the question. Yes, when we tell Rotarians and people around us that there have been only 2 cases of polio caused by the wild virus this year, and both of them in the month of January, everybody asks, how can you be actually confident that this is the reality? It's true that it is difficult to identify every single child who is paralyzed and therefore then investigate whether this is caused by polio. Although in most cases, parents, when they have a child paralyzed, will seek help from the health system. They may seek local help from traditional healers first, but eventually they will go to the health system. So we are pretty confident that we detect the vast majority of acute flaccid paralysis cases. However, what we've added to our very sort of sophisticated surveillance system in the Global Polio Eradication Initiative is environmental surveillance. We actually take samples from the sewage to see whether the virus circulates. If you find the virus in the sewage, that means that it has been recently excreted, because the virus will not survive in the environment for very long. And if it has been recently excreted, it means that it's circulating among the population, which is covered by that particular sewage area. Let me show you a slide that gives you an indication of what we've seen over the past 2 years. This is this graph on the right side of the slide is actually showing the cases starting from 2020, January 2020, at the bottom of the graph, and then going up to September 2021. The red and orange indications, bars, are actually cases. And you can see that the cases are reducing drastically. And the last orange and red bar is actually in January of this year. What you see also on this graph is gray and darker bars. And these indicates the sewage samples that have been collected in Pakistan and Afghanistan. And you see that this is also reducing drastically. We are collecting in more than 80 sites in Pakistan and Afghanistan on a regular basis, every week or every other week, samples of the sewage. And until very recently, until the end of last year and early this year, we were collecting and finding the virus just about everywhere in each one of those sites. Now, we haven't detected the virus, the wild virus, for close to 2 months now. The last time, more than 2 months actually, the last time was on 9 August in Pakistan. So you see that the virus is becoming less and less sort of prevalent, and that gives us strong confidence. And in fact, the data on the cases is true. Let me also add one point, if I may, Mike. When I was the director of the program in 2017, we had very few cases in Pakistan, 8 for the total of the year in 2017. 17. But the virus was being detected everywhere in the country through the sewage. And of course, we were sort of very anxious to see so much virus being detected, and we didn't find cases. And the following year, we had an explosion of cases of kids paralyzed. So indeed, it was a sort of an indication that the virus was still around. We were not finding the cases, but there were children being paralyzed, infected, and then paralyzed by the virus. So this year is very different. We don't have cases, but we also don't see the virus as much as we used to see it. Thank you.
Before I go on to Ravi, we have the political situation in Afghanistan that has changed rapidly. And I wonder if you can tell us if that's had an impact on delivering the program.
Yes, certainly the political situation in Afghanistan has had a huge impact on the country, on health systems, and on the delivery of healthcare in the country. I'm with regards to polio, and it continues to be, although the international agencies are trying to work with the government to see whether there can be good resumptions of health systems and healthcare delivery. I'm glad to say that for polio, the Taliban have never been opposed to polio eradication. They have indeed banned vaccination and immunization campaigns in the southern part of the country, which they had under control before they took the power, not because they were against the vaccination program, but because they didn't want information to be collected, sensitive information to be collected during those campaigns that could then be used by the international coalition against them. But since they have taken power, staff of the polio eradication program have actually stayed in the country for the vast majority of them, WHO and UNICEF staff, and have been in having discussions and negotiations with the Taliban so that they can resume massive immunization campaigns, not only for polio, but for other antigens. So we're hopeful that in the next few weeks, we will actually see sort of large-scale immunization campaigns in the country.
Thanks, Michel. That's actually quite a good segue to go to Ravi, because Ravi, at the time of polio eradication drive in Sri Lanka, there was also a civil war going on. How did you accomplish the task of vaccinating all the children who were in the conflict areas when obviously that was a serious challenge?
Michael, thanks a lot, and good evening, good afternoon, good morning to our listeners. Yes, 25 years ago, polio was still prevalent in my country, even as the war was still prevalent. Our first task, of course, Michael, was to convince the government that we needed to do national immunization days. And we had data of the success that Brazil and some other countries had, and we were able to present it at a meeting consisting of the government and UNICEF. And they agreed that this is the right way to go. However, there was a small problem, and that was budget. We needed about $5 million at that time. It's 25 years ago, which is quite a lot of money. And they said, we don't have the budget for this. We will have to put it into next year's budget, and we'll hold this whole thing up by 1 year. Now, that was really not good for us. So we told them, okay, we'll find the money. And I recall as I walked out of that meeting, my vice chair, who is now gone on, passed on, said, will you tell me how you're going to do this? And I sort of looked at him and I said, I don't have a bloody clue, I said. Well, that's where we started. We'll find $5 million. And nonetheless, anyway, we went to Rotary. Rotary gave a commitment. And then we had this big fundraising meeting. And the fundraising meeting consisted of the Minister of Health in his office, the Foreign Minister, the Ambassador for United States, Ambassador for Japan, Ambassador for UK, High Commissioner for UK, and UNICEF and WHO. We made a little speech, and by end of the meeting, we had the money we wanted. I mean, in fact, I finished the last speech saying, okay, we give you $1.5 million. We need the balance money, and we had it, they raised it straight away. Well, there you are. We said we had the money, so we're ready to start, and we've got the job done. But it wasn't so. When we found the allocations the government made, we found the entire north and the east of the country roped off, cordoned off. I mean, they were not part of this National Immunization Day. And we said, that's not acceptable to us. Rotary wants to immunize all the children, not some children. And doing 2/3 the country and leaving 1/3 out is just not cricket, as we would say it here. So they said, listen, we agree with you. We know we have to vaccinate the whole country. Can you please tell us how we vaccinate children when there is a war going on? Guns are being fired, cannons are being fired, landmines are going off. How do you expect us to do this? And we thought for a moment, and I said, we'll deal with it. And again, as we walked out, my deputy chair looked at me and said, how on earth are you going to achieve that? And I said, I don't have a bloody clue. And we started there. We had two problems. First was we were trying to establish contact with the then most feared and therefore the most elusive rebel or terrorist leader in the world. And secondly, we had to be careful that our efforts were not misunderstood by the security forces and we considered to be having a relationship with the terrorists. That would be worse. They would put all of us in jail. Now, I'm not at liberty to elaborate who helped us and how we achieved it, how we achieved getting through to the LTTE, that's a rebel leader, because there are lots of names involved and I wouldn't want to divulge them. But to cut a long story short, a few weeks later, a letter was delivered at my office, right at the security point of my complex. And the letter was signed by the feared rebel leader himself. And it had his insignia, a snarling tiger on the top, in the middle. And it was brought to my table by my most fearful secretary, whose hands were literally shaking when she said, letter. So I grabbed it from her, and the letter said in Talia, dear Mr. Ravindran, if you can persuade your government to stop the war for 2 days, then we are willing to lay down our guns for 2 days too. For our war is not with children. And you know, there we had the ceasefire. Of course, the war was stopped. We went to the government and actually I met the Prime Minister. She picked up the phone, called the Army Commander and said, this is the deal, you sort this out. And we called it Days of Tranquility. Our vehicles bearing the Rotary flag received the same respect and courtesy of the Red Cross flag as we traversed the vaccination booths in the so-called occupied areas. I recall meeting an old woman near the border area, and she wanted to know what we were doing there and whether we had come to canvass for votes. She said the only time people come is when they want votes. And when we explained about Rotary and our vaccination program, she shook her and said she does not understand, but if we ever participated in an election, then her vote was with us. And that was the only compliment she knew how to give. So in the consequent years, even without making a request, there was a tacit understanding that on National Immunization Days, they would be considered to be days of tranquility and the arms would go silent. You see, the terrorists trusted Rotary, even though they did not trust the government. Now, Michel referred to Afghanistan. It's interesting. Someone asked me, well, if you could stop the war in Sri Lanka, why can't you stop at Afghanistan? Well, a couple of things. In Afghanistan, you're dealing with 30, 40 different sects, tribes, or whatever, and no one really knows who you're dealing with. And secondly, in Sri Lanka, even the terrorists are educated. We have a literacy rate of over 90%. And I must tell you a story of my friend in Pakistan, Aziz Memon, who is in charge of polio, a very distinguished businessman. He was telling me a story of how he was once in a hospital in Peshawar. And he had been there because they had gifted some beds or something, and he was waiting for the medical superintendent. When the gentleman next to him, he was armed with a gun, wearing very heavy clothes. I mean, clearly he was Taliban, although no one had the guts to ask him that, was seated next to him with a child. And it was, the child was also wearing heavy clothes. And Aziz told him, you know, maybe you should take off a sweater and a warm clothes because she's sweating. And this Taliban leader looked at him and says, don't you understand? She's got the fever. And that is what God wills, and she will have it. Just because you take off these clothes, it doesn't mean that it will go away. But I beg your pardon, she had polio. And he said that just because you take off these clothes, etc., and let her walk around, this polio won't go away. You see her legs. This is what God will. And of course, Aziz didn't want to talk too much to her and talk too much to him. And then he explained about what Rotary is doing with polio. And after some time, this gentleman said, you think your Rotary can cure this child? And Aziz says, well, we can't cure this child, but I can tell you, if you take these drops, these vaccines, all the other children in your village will not have to go through what your child is going through. And they broke off the conversation. Aziz gave him his card and left. And weeks later, he got a letter, just 2 lines saying, Saab, thank you very much for your advice. I have now made sure that all the people in my village are vaccinated. So it was a question of education. Michael.
It's amazing. It's amazing, Ravi, how these side stories always tell a particular important thing about relationships and how important they are in terms of vaccination. Can I move on to Michel? Michel, I think it's really important to understand for our listeners that there's a difference between wild polio and vaccine-derived polio. According to the Global Polio Eradication Initiative, with regard to wild polio, as of 23rd of September, there were just the 2 cases that you talked about. But there are other cases. In Pakistan had 8 vaccine-derived cases, and in Afghanistan, 43 vaccine-derived cases. Can you explain the difference and the concern around these cases?
This is indeed a very serious problem. The vaccine-derived poliovirus cases is caused by a virus, which is, well, let me start backtrack and say, to eradicate polio, we're using the oral polio vaccine. This oral polio vaccine contains a live virus, which has been attenuated in order to protect the children. So when a child is vaccinated with this live attenuated virus vaccine, the child is protected. But because it is oral, eventually the child will excrete this vaccine virus. And as a result, in the areas where sanitation is not optimal, children that are in contact with this child vaccinated may be infected also by this vaccine virus. This is okay. Initially, it's okay because it means that the kids that are around the vaccinated child get also vaccinated by contact. The problem comes when too many kids are not vaccinated. So you have a few that are vaccinated and many that are not vaccinated. And therefore, the vaccine virus is allowed to move from one unvaccinated child to another unvaccinated child for a long time. And in doing so, over time, it will eventually mutate. And in mutating, it can regain the ability to paralyze, to be harmful to the kids. This is what we call a vaccine-derived virus, which caused those cases. And this is a true problem. We have several outbreaks of vaccine-derived polio in Africa, in several countries in Africa. And as you've mentioned, we've had in outbreaks in Pakistan as well as in Afghanistan. What we are doing is, over the past 10 years, and also thanks to Rotary financing, but also the Bill and Melinda Gates funding, we've actually launched into the development of a novel vaccine, a novel oral polio vaccine, which is genetically modified in order to avoid the risk of the vaccine virus mutating and becoming dangerous. This vaccine was authorized for use at the end of last year by the World Health Organization in the context of a public health emergency. And since March, it has been launched in several countries. 7 countries have actually used 80 million doses of this vaccine. And just last week, the Strategic Advisory Group of experts on immunization of the World Health Organization reviewed the data on the use of these vaccines and has authorized now that this vaccine be used in a more general manner by all countries. So we are going to be able not only to stop those outbreaks with this vaccine, but also to avoid that new outbreaks emerge as a result of poor quality vaccination.
And look, there's some really important lessons for us in this with regard to COVID and COVID vaccines, because we know they're not perfect. But what we do see is development going on all the time to improve the situation, because one of the things that I wanted to do at this meeting was also to try and learn lessons from what's happening with regard to polio and how we can perhaps apply it in other circumstances. But one of the things I think, Ravi, that's interesting to me is that you run a company of over 1,000 workers, and you also had the responsibility of 1.2 million Rotarians around the world. How do you find the time to then devote to Rotary as you have? And also, I wonder what motivates you, what motivates other people to make this kind of contribution?
Michael, you know, before I answer that, I want to, you spoke about polio vaccines and how there's a lesson in it. And I want to share with you a story of how the polio vaccine has helped me personally, my country to benefit. You know, in Sri Lanka, we had a project called, we did a project called the Cancer Detection Center. It was a very simple building, nothing fancy. Women could go there for early detection screening for breast and cervical cancer. But because of the relationship we had built up with the government on polio, they agreed to support us with the doctors and nurses, which means that they really ran it. And our part, we could make available the building, the furniture, the consumables, and so on. Our goal was not just screening patients who came to the clinic, but to get the patients who had positive results onto the next step they needed so that they had the best chances at life, because we have caught this cancer early. We understood that people were coming to the hospital sometimes when the cancer was already too advanced. We knew that if we could detect the cancer in the very early stages, we could save lives. We also undertook the public awareness and education aspects of it because the government gave us all this support. But, you know, in the first 5 years, we had screened approximately 12,500 women, all free of charge. Nearly 2,500 of them were identified as requiring further investigation, and we sent them on to the government's cancer hospital and where they were treated. Now, it was about this time when I met with a gentleman called Partridge, Ed Partridge, a former head of the American Cancer Society, a Rotarian from Birmingham, USA. Let's say he was just a nice guy like you and me, but an expert in his field, willing and eager to share his knowledge and advice. Through him, I saw our project through different eyes. You see, cervical cancer was unique in that it is the only cancer that can be completely prevented by a vaccine, you know, like polio. I learned that HPV vaccination in women prevents the disease, and HPV detection at screening identifies those women who may harbor a precancer, which can be treated and prevented from being a cancer. When I shared this information with my clubmates, there was palpable excitement. You know, nearly 2,000 cases are diagnosed in Sri Lanka every year, and nearly half of these women die. Imagine, here was a chance that almost all of those deaths could have been avoided. So by vaccinating girls against the virus, screening women for signs of it, that this is a cancer that could be wiped out completely, we realized that we could actually eliminate cervical cancer from our country. Now, to achieve that, in theory, all we needed to do was vaccinate every single child in the 10 to 14-year-old age group. The HPV vaccine has already been confirmed to be potent and a proven success. In addition to the vaccination, we needed to screen with HPV testing each 35 and 45-year-old woman. The HPV test was very viable, very doable compared to the complexity of pap smear programs we were now doing, the personal nature of it, which often faced resistance. So we obtained a new generation mammography unit. We added an ultrasonic machine which is critical for accurate early detection of breast cancer. And as we planned, we increased the effectiveness of the cervical cancer screening through HPV testing rather than pap smear process. You know, the point I'm trying to make is because of polio, two things happened. We built a relationship with the government. And in this case, the government actually allowed us to send their technicians for technical training to one of the best comprehensive cancer centers in the USA. We put in a second Cobas brand HPV testing machine. We helped train midwives and corpus, I think you call it, and supported our public awareness drive. So, you know, we were making huge advancement, and the government of Sri Lanka understood our excitement. They showed their commitment by agreeing to fund the entire cost of vaccines. They negotiated and obtained HPV vaccine at Gavi prices for a further 10-year commitment. And in the very first round of vaccinations, 80% of the population of 10 years old in the country were covered in less than 6 months. Our goal, Sri Lanka becoming cervical cancer free, was becoming real. You know, to us Rotarians, this was polio plus all over again. Yeah. We were using and leveraging Rotary influence to put together a master project. We were saving lives. We successfully did it with polio in our country, even through the throes of a civil war. Now in peacetime, we could do it again with another disease, and we were on our way. So
Ravi,
I think Sorry, Michael.
In this series, we had Professor Fraser, who was the inventor of that vaccine. It came in and we had them there. And of course, the people who are attending this can go into the World Federation of Public Health Associations website and listen to that talk by Professor Fraser. But the message that you're getting is the lessons from polio, then go on to HPV, and where else in the next form of vaccination. In the meantime, we have a question from Dr. Jogasai, who I hope I pronounced his name correctly, and he's asking about Pakistan and the drop in the numbers of people with polio. And he asks, is that due to this new vaccine? Whereas actually, I think, Michel, you addressed the issue in terms of wild polio virus and vaccine-derived polio virus. Would you like to just clarify that one for us?
Yes, the new vaccine I referred to, the novel oral polio vaccine, is to address the risk of outbreaks caused by the vaccine-derived virus. But the question about why there is such a sudden drop in cases in Pakistan and Afghanistan, I haven't addressed. And it's indeed a very interesting question, because last year we had 140 cases in both countries, and this year only 2 so far. Well, at the same time, last year we had 120 cases, so there's a significant difference. So my colleagues at the World Health Organization and in the GPEI are exploring a possible explanation for this drastic improvement. Some of the hypotheses is, of course, first, because there were many kids affected and there was wide circulation of the virus, there's some natural immunity that has been established, but that's probably not sufficient. There have been also good immunization campaigns. We stopped immunization for 3 or 4 months during the start of the pandemic, and then the program resumed in June of last year, the campaigns, and perhaps the quality of the campaigns were better than before because there was some better acceptance on the part of the communities, of the teams that were coming to vaccinate. But I think perhaps one of the most sort of compelling reason for this improvement is the fact that the pandemic itself has forced the government to stop movements of populations. Yes. There were massive movements of population across the border between Pakistan and Afghanistan, back and forth, and mostly of Pashtun communities. And over the past 10 years, 80% of the polio cases have been in the Pashtun communities, which represents in Pakistan only 15% of the population. So the fact that these communities were no longer crossing the border and they were sort of more stable meant that the vaccination campaigns could reach them more easily, find all of the kids, and also that the virus would no longer play ping pong between the two countries and eluding vaccination campaigns. That's one possible additional explanation.
And we've had another comment from Maksud, and I'll try and address any comments I see coming in the chat area about movements and refugees from Afghanistan and what's happening there. But it feeds into the next question I was going to ask you there, Michel. We know that there's only been one successful case in the world where we've rid the world of a disease. That was smallpox. And people our age have probably still got our vaccine mark on our arm. And remember, we needed to have that to travel. So if even in those days, there was if you like, a vaccine passport. But now we're close to having the World Health Organization declare the world free of the second disease, polio. What else really needs to be done, and how much concern have we got about that movement around the Afghanistan-Pakistan border?
As long as the virus survives somewhere, there's a risk everywhere. So that's why we need to continue our efforts to vaccinate, and not only vaccinate in Pakistan and Afghanistan, but vaccinate in about 40 or 50 countries that are vulnerable, where if the virus comes back, it could reestablish itself and cause major outbreaks. So vaccination must continue until the virus is fully eradicated, until we no longer see the virus, neither in cases nor in the sewage. But we will need to continue to vaccinate for a period of time after that. First, because we need at least 3 years without detection of the virus anywhere in the world, or anywhere in sewage or in cases, to actually be in a position for the Global Certification Commission to guarantee that the virus has been eradicated. That's the first thing. The second thing is that while the wild virus has been eradicated, it is still present in many laboratories, in many companies that are using it for research purposes, for producing vaccine. So there could always be an accident. So we need people to be protected to avoid sort of the risk of outbreaks caused by an accident from a laboratory. And you mentioned smallpox. The last case of smallpox was not in Somalia in 1974. It was actually in the UK, in Birmingham, when following an accident in the laboratory, the virus escaped and actually contaminated several people and killed one. So it is important that we also work very hard to reduce the number of places which maintain the polio virus for manufacturing purposes or for research purposes. So vaccination needs to continue for a number of years to be sure that we actually have fully eradicated this disease.
Ravi, can I go back to your leadership role in Rotary, and where you've played an absolutely key role in ridding the world of polio? Can you explain how Rotary became involved, how it became a leader, why it was so important to bring others then into the campaign, and perhaps apply some of those lessons to what we might be doing with COVID vaccines, beyond what you've already told us around HPV, which was really interesting.
Michael, I mean, I'm a Rotarian, and the role I play is immaterial. What matters is the leadership role that Rotary plays. So people like you, people like Michel. Our story really began way back in 1979 in the Philippines. Rotary had taken on a project to immunize children against polio. The campaign was a success and replicated in 5 more countries. Following the eradication of smallpox, which you just heard about from Michel, and with the success of what we call the 3H projects, that's Health, Hunger, Humanity projects, the Rotary president at the time, Carlos Canseco, asked Dr. John Sevier, a renowned pediatrician and researcher who worked at the National Institute of Health, if there was another disease that could be eradicated. Dr. Sevier suggested polio because there was a safe, effective oral vaccine that could be easily delivered by health workers and volunteers. Now, in 1985, Rotary launched the Polio Plus program, that's vaccinating for polio plus 5 other vaccinable diseases. And there was a fundraising campaign to raise $120 million because that was thought to be the amount of money necessary to buy enough vaccines to vaccinate every child under, 4 or 5 years. By end of the year, 1988, we had raised double that amount, $247 million. This was the moment that WHO truly believed that eradication of polio was possible and adopted the resolution to eradicate polio the same year. This also marked the establishment of the Global Polio Eradication Initiative, or as we know it now, GPEI, which included Rotary, WHO, UNICEF, and the US Centers for Disease Control and Prevention. The GPEI was later joined by the Bill and Melinda Gates Foundation and Gavi, the Vaccine Alliance. WHO and UNICEF were and remain even now the technical implementing partners, while CDC provides laboratory support as well as additional technical expertise. Rotary had shown that a volunteer organization could meaningfully lead and even contribute to a public health initiative through fundraising. I mean, today we have raised over $2.2 billion to the effort, and that we could raise awareness, we could do advocacy, which was all complemented by the needed technical expertise to guide the program, the technical expertise coming from our partners. Now, because of Rotary's vision, of course, you just heard from Michel how the number of polio cases when we started was 350,000 or 1,000 a day almost in 125 countries, and we're just down to 2 cases so far this year, one in Pakistan and one in Afghanistan. And that about gives you a synopsis of how Rotary started and where we are now.
And my other part of that question was, how do you think that the lessons that we can get that might apply to widespread adoption of COVID-19 vaccines?
So one of the lessons we learned in the polio eradication effort is the need to mobilize communities to create demand for an acceptance of vaccines. I mean, I told you how we did it in Sri Lanka with HPV. But this process of educating people includes providing public messaging about why vaccination is important, information about the safety of the vaccine, scientific information, not the nonsense that we read very often, information about where and when vaccinations are taking place, transporting of the cold chain equipment, and all this often requires identifying trusted voices at the national and at local levels to deliver these messages, such as traditional and religious leaders. In India, for example, there was a problem with some of the Muslim communities. So we actually work with the mullahs to get together and say there's nothing wrong with this and that you should continue to get vaccinated. We work with celebrities, including actors, sports figures, polio survivors, anyone who has the ear of the community to help in the messaging. I recall in Colombo when we were doing this National Immunization Day, it was also the final of the one of the big cricket tournament finals. At that time, Sri Lanka was doing extremely well. And we were playing Australia. We were playing Australia. So we got the captain of the cricket team actually put a message on the TV saying, don't come to watch the cricket. Go and get your child vaccinated. That's more important. You see, these trusted community voices can help address the issue of vaccine hesitancy by acting as role models, by taking the vaccines themselves. And I think these same strategies can be adapted to the COVID-19 context. It's the same thing. Rotary doesn't want to get involved with buying vaccines. Apart from that, we are willing to do everything. And as an ordinary human beings, citizens, we could do this. Because polio immunization taught us the importance of proper handling of cold chain equipment. That's exactly what you need for the COVID-19.
Yeah.
The same skill sets are needed now, as are the connections we brought to bear on the media and so on, and propagate the value of the vaccination.
Ravi, it's interesting in Australia where I live, each jurisdiction has different controls over vaccine and so on. It's not a federal matter. In my own jurisdiction in the Australian Capital Territory in Canberra, today we heard that over 98% of our population over 12 years old have had their first dose of the vaccine. And
Wonderful.
so we're expecting, in another couple of months that we will have a very similar figure completely covered. And it's a matter for us to be very proud of, and for other jurisdictions then to try and match, because it becomes a bit of a competition, a little bit like cricket between Australia and Sri Lanka. You may not understand this, Michel, but it's a very important part of our cultures. But Michel, you've been part of Rotary, but you've played a key immunisation role with the World Health Organization and within Gavi. A key element of your work, as I understand it, was ensuring widespread and equitable access to vaccines. Now, you can't get everybody vaccinated if you don't have the vaccines. And I'm wondering if you can just share with us what the message has been here, both with regard to polio, but I think now much more importantly, with regard to COVID vaccines.
Yes, as Ravi mentioned, you need this sort of acceptance by the communities of the vaccine, but you also need to have the vaccine available for those communities to get vaccinated, and good information on the vaccine so that people have confidence it is safe and effective. One of the problems that's made the world decide to establish Gavi back in the year 2000 was this gap that existed between the rich world and developing countries. There were several vaccines, several antigens that were available to the rich countries, such as pneumococcal vaccines, rotavirus vaccine, Hib vaccines, that were absolutely not available to the developing world. And when they were available, they were much too expensive. Hepatitis B was another one of these vaccines. So Gavi was created to actually try to fill that gap between the poor and the richest countries. It has been extremely successful in the past 20 years. And in the context of COVID, Gavi, together with WHO, UNICEF, and CEPI, have established what we call COVAX, which is an entity that is meant to procure vaccines from all manufacturers and make them available at preferential prices, at lower prices, to the countries that perhaps don't have the purchasing power of the US or European countries. COVAX is working very hard to get access to the vaccines and then distribute them to the developing countries. Unfortunately, one of their objectives was to purchase 2 billion doses of COVID vaccines by the end of this year and distribute those vaccines to the poorest countries in the world. Unfortunately, they have the money to purchase the vaccine, but vaccine has not been available on the market to actually be purchased by COVAX. So this is now gradually improving, but it's been extremely difficult for COVAX to purchase vaccine because the vaccines were being preempted by the richest countries in the world. Vaccine equity is absolutely going to be essential for us to be able to stop this pandemic. Until all people, and around the globe have access to vaccination, there's a risk that the COVID, SARS-CoV virus could mutate again. So we actually want to vaccinate and have access to vaccines for the whole world so that we can stop the circulation and the possible emergence of new variants of the SARS-CoV virus.
You know, those of us who work in public health talk about the social determinants of health, and basically the work of Sir Michael Marmot for the World Health Organization illustrated that basically the wealthier you are on a statistical basis, the wealthier you are, the healthier you are. And this is one of the ways we can, and vaccination really provides an opportunity to counter that to a certain extent. It will always remain. Because wealthier people have access to treatment and better nutrition and a whole range of factors. But in vaccination, it is an opportunity for us to do that. And that's part of, I think, has been the drive for Rotary. I'd like to just take us to, and we're running out of time. I'm just checking to see if there are any other questions. I think we've answered those that are on the Q&A. But Ravi, you had a very personal experience with regard to polio regarding your mother, and I think that has been a very important motivator for you. But I wonder if you can just share a little bit and what the lessons are that we can draw from that.
Michael, I don't know about the lessons. My mother was born in Sri Lanka. You know, she was a bright, beautiful girl who grew up to develop a remarkable strength of character. She married quite young, and I was born about a year after that, so that by the time she reached the age of 30, I was already about 11 years old and off at boarding school. So I wasn't home that day when she woke up feeling not quite well. I wasn't there when she went to wash her face and found that she found it difficult to lift her hands. I wasn't there when she sat down to rest and realized that it was becoming difficult for her to breathe. And I wasn't there when she was rushed to the hospital, completely paralyzed in hours, unable to move. She heard them saying she was dying, and that she heard them saying that she needed to be in an iron lung, although she didn't know what it was. I was so young at that time, there was no one really told me how serious the situation was. I knew about polio, but no one said that word to me. Someone came and took me from school and brought me to my grandfather's house, where my brothers and younger brothers and sisters and I stayed, while my mother lay in the hospital, the iron lung pushing her every breath in and out for her. It happened to be that my grandfather was a Rotarian, and the next evening he was hosting a committee meeting in his living room. I remember very clearly the phone ring and looking down the stairs as my grandfather came out to answer it. I couldn't hear what was being said, of course, but I could see his face turning gray, and I could tell that the news was not good from the hospital. The doctor had said, you have to put her on a ventilator or she hasn't got much of a chance, but we don't have one to give her. This was Sri Lanka in 1963. There were only a few ventilators in the country, and all of them were already in use. And there he was holding the phone like that, and at the bottom of the stairs, devastated, when his fellow members of the committee crowded around him. But they didn't just listen sympathetically. They stood there and worked out how they were going to get that ventilator. One of them was a bank manager. He called a minister of state to have the foreign exchange released, because at that time we had foreign exchange restrictions. Another was the manager of Swiss Air, who said, I will have that machine flown in by tomorrow night. And in the meantime, the doctor himself made arrangements for the machine in London. There was so much red tape at that time, but somehow those friends made it all fall away. By the following morning, this machine was on a plane with a band around it saying, rush me, I could save a life. I mean, imagine ventilator, today it's common. That time we had to go through so much trouble to find one. By that evening, it was at the hospital and it was helping my mother breathe. She was on it for nearly a year, flat on her back, unable to do anything for herself, unable to even talk, but alert in her mind. My father did not leave her even for a night. He slept on a table in the waiting room since he couldn't get into the ICU. During the day, he went to work and he came back to the hospital every evening, where he sat hour after hour in a wooden chair outside the ICU and then on the table sleeping, making sure that machine never stopped and willing her to recover. After a few weeks, he had a sign hung on a small board over her bed. It said, every day, in every way, I'm getting better and better. And she was. One day she could move a finger, another day she could move a toe. You know, my mother was carried into the hospital on a stretcher, but when she left it, after a year, she walked slowly with a walker, but upright on her feet. She was never physically the same again, but she came home to live another 48 years before she passed away 8 or 9 years ago. So, you know, nearly 55, 60 years ago, my mother's life was perhaps the very first to be saved from polio by Rotarians. We have saved millions of lives since then. And we will save hundreds of thousands more in the years to come, in the centuries to come.
Ravi, it is a really lovely story and an interesting way to conclude, remembering that there are many people in the world today who, thanks to COVID, have needed ventilators and have not been able to access the ventilators. And so the challenges are still there in front of us, and ones that we'll still wrestle with. Ravi Ravindran, Michel Zaffran, thank you so much for being part of this webinar today. And for those who want to pass on to their friends, if you go into the World Federation of Public Health Association website, just WFPHA.org, you will be able to find not just this webinar, but also a series in the being prepared by the task force on global immunisation policy for the World Federation of Public Health Associations. Thank you very much, and I'll declare this webinar closed.
Thank you, Michael. Michael, you yourself do such a great job. Spend so much of your time in all this stuff. I mean, I truly admire you. Thank you very much.
We're very lucky to have the opportunity. Thanks, Michelle.
Thank you.